So, sir, I've started the live streaming.
Okay.
So, it's exactly. So, should I start, sir?
Oh, yes.
Namaskar. Welcome to 198th edition of Happy Learning Masterclass webinar series in association with Calicut, Kannannur, Kasargod, Perinthalmanna and Wayanad Obstetric Gynec Societies. Here, we are going to discuss the rupture uterus, OASIS, and MTP Act. Before we start the program proper, I would like to invite you all for a short prayer and then we can take the program forward.
ആദ്യം ഫോണിലൊക്കെ ഒന്ന് എടുത്തു ടാബ്ലറ്റ്
I would like to introduce my co-convener, Dr. Rijesh Ravi. He is an assistant professor, Department of Gynae, Malabar Medical College, Kozhikode, secretary of the Calicut Obstetric Gynec Society, having many different posts in FOXY Quiz Committee Coordinator, South Zone, KFOG Academic Committee Chairperson, KFOG PG Forum Coordinator. He's organized FOXY South Zonal Conference 2023 and co-convener of monthly Badlav series by FOXY Quiz Committee and also co-convener of FOXY Quiz Committee. That's me. And I would request Dr. Rijesh, if you would say a few words about me before we take the program forward.
Is Rijesh there?
No, he was here, but I don't see him anymore. So, sir, I welcome you to give the formal welcome address before we take the program forward and invite. We have two coordinators, Dr. Kalpana G, who's from Malabar Medical College, Calicut, Kerala, and Dr. Rekha Rajendra Kumar ma'am, who's the president of Bangalore Obstetric Gynec Society and has just finished an immensely successful conference. So with this, I would like to stop sharing my screen and requesting, sir, please give your welcome address. As you all know, sir is going for President FOXY this year, and he has been working hard in this program for the last more than 3 years. This is the 198th edition, and he's been very consistent with it. And this is his 4th round with all FOXY societies. So over to you, sir.
Thank you, Dr. Asha, for kind words. It gives me immense pleasure to welcome you all on 198th episode of Happy Learning Masterclass web series. And today's joining society, Calicut, Kannur, Kasargod, Pariyanthalmanna, and Wayanad. I welcome Dr. P.K. Sekharan sir. He is chief guest for today's webinar. He is here to bless us. He is man of commitment because just now he is at USA, and from USA he has joined this webinar to bless us. Thank you, Sekharan sir, for the same. Of course, you are always with me in any of my academic activity. I am always blessed with your blessing. Thank you for joining and thank you for coming to bless us. I also welcome Dr. Omana Madhusudan Madam from Wayanad. She has kindly consented to be guest of honor to bless the webinar. And good old friend Dr. Kunji Mohiddin from Perianthal Manna and President of KFOG. I welcome both the guests of honor to this webinar. I also welcome one learned speaker, Dr. Mumtaz Madam from Perianthal Manna. She is going to discuss very interesting topic of rupture uterus. And to chair that very session, I welcome Dr. Geeta Mekoth Madam from Kannur, Dr. Elizabeth Madam, Joseph Madam from Malia Madam from Kasargod, and there will be reverse panel. Panelists will be asking question, and being a moderator, I will be answering. And topic is MTP Act and its amendment, what gynecologists should know. So many times, few of our friends were asking me, even after this amendment, so many of our Foxian friends have a confusion in their mind about provisions of MTP Act. So let us discuss that. So we have kept that topic for today's discussion, and it will be reverse panel. So welcoming all the learned panelists for that very panel, Dr. Vidya Nambiar Madam from Kasargod, Dr. Nirja Madam from Kasargod, she is unable to join. Dr. Bhavya Madam from Kannur, Dr. Lakshmi Madam from Calicut, Dr. Kochumani Madam from Perianthal Manna, Dr. Shiv Kumar from Wayanad, Dr. Uma and Dr. Suma from Wayanad, Dr. Mini from Kannur, Dr. Sabita Madam from Calicut, Dr. Bhavin from Calicut, and Dr. Simi Kurian Madam from Kannur. I also welcome one more speaker, Dr. Jyoti Chandran Madam from Calicut. She is going to discuss about management of obstetric anal sphincter injury. And to chair that very interesting session, I welcome Dr. Raghavendra Prasad from Kasargod, Dr. Vinay Chandra from Calicut, and Dr. Professor Ajit from Kannur. I also welcome Dr. Asha Jain, who is convener in this series since long, and Dr. Rajesh, who have been convener for this webinar. Of course, I would like to say about Rajesh, he has helped me a lot as far as this webinar is concerned. I also welcome two learned coordinator, Dr. Rekha Rajendra Kumar, President Bengaluru Society, and just mentioned by Dr. Asha, she has completed very successful conference, FEMCON, just 2 days back. So welcome Dr. Rekha. I also welcome Dr. Kalpana ji. She is also one more coordinator. She has also helped us in this webinar in many places. So welcome you all, President and Secretary of Calicut, Kannur, Kasargod, Perianthal Manna, and Wayanad, and all the delegates who have joined this webinar. In era of COVID, when I started this series with 3 friends, I never thought that this series will continue up to this much episode. Because at that time, my intention was to meet Foxian friends on virtual ground to discuss focus topic and to discuss one medical legal issue, how not to get up into, and if at all in, then how to get rid of it was my motto. But with encouragement and blessings of so many seniors and our friends, it is continued. And just I mentioned, it is our 198th episode. This is our 4th round with Foxian societies. So this was our journey of Happy Learning Masterclass web series. So without wasting much of your time, welcoming you all, over to you, Dr. Asha.
Thank you, sir. Now I would like to introduce our chief guest, Dr. Shekharan, sir. Welcome, sir. He is the past Vice President Foxy hasn't sent a big CV. So, sir, you are a pioneer in so many things, so much work on endometriosis. So, welcome to you, and over to you for your words of wisdom.
Thank you, Dr. Asha Jain. Thank you, Dr. Patel, who is my friend for a long, long time now. And I appreciated your work on this webinar, which is running very successfully over the years, who has helped us from the FOXI to benefit from your meetings, and I congratulate you for that. Now, I could see the Kerala societies are part of this webinar today, and my friends from Kasaragod, Kannur, Calicut, Wayanad and Perinthalmanna, I could see many of them, especially my colleagues and respected President of KFOC, Dr. Kunjumoideen. He is our leader from Kerala. Dr. Omana Madhusudanan, who has started the Wayanad Society, and now it has grown to very, very successful society. And then we have got all our friends from Calicut and other areas. So I thank Dr. Patel for starting this webinar at a difficult period of where we were not able to meet. And then it has been very successfully being conducted. I could be there in many of your meetings, and thank you for that. And this particular webinar focusing on certain aspects of medical legal aspect, which is very, very important for us to understand the implications of the modifications on the Act. And also, though rare, the rupture uterus, which we might have happy to see that is not very much actively seen nowadays. In our time, it was one of the very major work which we were doing. In the middle of the night, getting very difficult case for rupture uterus, everything. And then that has gone to a lesser incidence now. But when it becomes rare, then we used to be out of touch for that subject. But we have to be very sure about what it is what has to be done in such a case, where to preserve the uterus and that. And my colleague from Perinthalmanna, Dr. Mumtaz, is very capable of dealing with any sort of subject, any type of subjects, and we are going to wait for. So there are very good topics today. Anus-sphincter injury is again, we have tried to prevent it, but still occurring. So these are all important topics of day-to-day importance in our practice. And I wish all the best for the webinar. And I wish both Dr. Asha and Dr. M.C. Patel in their the role in the FOXI in a much higher level, and hopefully and pray and God bless us that they make through the contest on there. So thank you once again. Thank you every delegate, and thank you once again for this opportunity. Right.
Thank you, Sekharan sir. Of course, you are always with us in any of our academic activity, and your mere presence is enough to encourage us, to inspire us for this type of academic activity. Thank you, sir, for sparing time to bless us.
Thank you so much, Shekhan sir. When I could not contact you, I was in such a hassle. But then Dr. Rijesh told me you're not here. So thank you so much for joining in.
Yeah, it is 5:30 a.m. So very good.
My God. And you're all ready.
Yeah.
Great.
Sorry.
So, sir, now we have two guests, Dr. Omana and Dr. Kunjumoideen. So, Dr. Omana ma'am is HOD, Department of Obstetrics and Gynae, Vinayaka Hospital at Wayanad. She is working in Wayanad only for the last 35 years. She's the founder president of Wayanad Society, past VP of KFOG, member Practical Obstetrics Committee, VP IMA, and Chief Coordinator Pradhan Mantri PM SMA Scheme, Captain MD NMSR Wayanad District. Her areas of interest are high-risk obstetrics, adolescent health, and sickle cell anemia. Welcome, ma'am.
Hello, a warm good evening, most respected Patel sir, my own dear Shagaran sir, and my dear KFO President Dr. Kunjumaideen. I understand it is a 190th Happy Learning Masterclass series for the last 3 years by MC Patel sir. I congratulate him and I wish him all the best in coming Foxy elections.
Thank you.
I tell you, sir, I have attended at least 100 classes of yours, and it's very useful for practicing obstetricians. Today's topics also, as Shairan sir told, rupture uterus, MTP Act amendments, and OASIS. Especially MTP Act amendments, we obstetricians work hard but fails to record and go for medical legal things. And I know Patel sir was always with us with Subhash sir. For any medical legal problem in Kerala, he used to help us like anything. So I am sure we will be very much enriched and we will go back with so many practical points today. And my special congratulations to convener Dr. Asha Jain and my own friend Dr. Rajesh. Dr. Asha, I wish you all the best in the coming Foxy elections. And Patel sir and Asha, our blessings will be always with you. Now, the coordinators, Dr. Rekha and Dr. Kalpana, my friend, they also were doing wonderful work to put maximum the webinar the best. And I thank them also. And I especially thank for making me, honoring me today and making our society a part of this webinar. Wishing the webinar all the best and thank you once again. Thank you.
Thank you. Thank you, Umana Madam, for sparing time. Yes, rightly mentioned by you. You had been in this series in past also as a faculty, and you have always honored our invitation. Thank you, Madam, for sparing time to bless us.
I think, shall I speak?
No.
Let me introduce our guest of honor for the next guest of honor, Dr. Kunjumoideen sir. Sir is the president of CAFO, as well as sir is the managing director of ARMC IVF's chain of IVF centers, and also the chairperson of Kerala chapter of ISA. Telling about sir, like MC Patel sir is also an ardent fan of using technologies and webinars and enhancing the medical education and continued medical education, and has also made a revolutionary change in our CAFOG CMEs as well as academic projects. So sir will be an apt person to do the guest of honor talk in this webinar, and it's one of the long-running webinars since the 2020. We have been doing the Happy Learning program, and I would like to hear the words from Kunjumoideen sir. On to sir.
Good evening, all. Thank you, Dr. Rajesh, for the kind words. Respected Chief Guest, Dr. Shagaran sir, and Dr. MC Patel sir, who is the master brain behind this mammoth webinar series, which is going to complete the 200 mark. And all the dignitaries, faculty, dear delegates, and all the people who are working behind for past almost 4 years behind this webinar. And it is indeed a great pleasure to participate in any of the academic programs organized by Dr. MC Patel sir, because that will have its own class and standard of academics in whatever the program he is organizing, whether it is a physical program or the virtual program, whatever it is. Like his electrifying talk in all the medical legal situations in obstetrics and gynecology. And I hope this today's the reverse panel on MTP will be a big hit, and that will keep all the delegates to attend this webinar till the last minute. And with these few words, I wish this webinar a grand success and also a much bigger grand success and a thumping victory for our dearest MC Patel sir in the coming Foxy election. Thank you, sir.
Thank you. Thank you, Kunju Waiddin. You are always a good friend and you have been with us in any of our activity. Thank you for sparing time to bless the webinar. In last webinar, you couldn't join due to your ill health, but still you have kept your promise to join in this series again. Thank you. Thank you very much.
Thank you, sir.
Thank you, sir. Requesting blessings for me as well.
Yes.
Yeah. Best wishes, madam. Best wishes, Ashadin.
Thank you, sir. Thank you, sir. So now I would request Dr. Kalpana, ma'am.
Is she there, Kalpana?
I saw her, sir. I saw her, but
Yeah,
I
she
don't
was
see
there.
her anymore. Rajesh, Dr. Rajesh,
Yes, madam.
would you say a few words about Shekharan, sir? I feel very inadequate about his CV. You know?
Actually, I didn't want to intervene in between because sir needs no more introduction to any of the audience.
Agreed.
That's why sir is my teacher. Sir is almost everybody's teacher, and I feel very much ashamed to introduce sir to people because there is nobody else who doesn't know sir. And sir has been the pillar. We have three pillars, as we say, for CAFOC. Sir is the main pillar from Calicut, along with Paili sir and Rajashekaran sir. And with sir's blessing, we had gone good heights in our society, Calicut society, as well as Kerala Federation, as well as South Zone or Foxy, whatever it is. And sir has been the pioneer in gestational trophoblastic disease and has made them most important study, and is still the member of FIGO's planning for vascular mode studies, and sir's interest is preeclampsia. I was lucky enough to be with sir, sitting near to sir for 2 years by doing my DNB, and I cherish that moment every time, and that is my nothing more to say, and I'm happy
Thank
to
you so
be.
much. Thank you so
Yeah.
much. See, I saw sir in 1989 when I was a junior resident, and he had come to Nagpur conference for a lecture. So that's how far back I know him as a teacher. But when you have to say something, it's very inadequate. Means what
When
do you
when
say?
you saw sir as a teacher, I was just being born, madam. That is the difference, and he's my teacher also.
Yeah, but in 1989, I was a JR and I heard sir at that time. So thank you, sir. And please forgive me for not making a big CV of yours.
Thank you.
Actually, if I could say a few words, sir has done a lot of work in the field of gestational trophoblastic disease, both in national and international level. Something I
Thank you. So we have our chairpersons. Rajesh, you want to introduce or I go ahead?
Yeah, I will
You
introduce
go ahead.
madam.
Go ahead.
Yeah, this is we have first session on rupture uterus by Dr. Mumtaz, and the chairperson's first session is Dr. Geeta Mekut, madam. She is the president of Kannu Society. Madam has not joined it, I believe. So we'll go with the other chairpersons. We have Dr. Elizabeth Joseph from Wayanad. Madam is the professor and HOD. I was previously working under madam at Mupens Medical College, Wayanad, and has done her studies from Calicut Medical College. Presently is the scientific chairperson of Wayanad Society and has a lot of publications and journals at state and national level. A good teacher and a good leader. So welcome Elizabeth madam to the webinar. Along with madam, we have Dr. Maya Malya madam. She's a very nice lady. We is a consultant at Malya Hospital, Kasaragod. Madam was past president of Cox, had made a lot of advances in Kasaragod Society when she was the president of Kasaragod Society. She's a laparoscopic surgeon and trained colposcopy, and has been the major part in the organizing of the IKCOG 2011 in Kasaragod, and was the treasurer of IKCOG in 2019. And she is also the coordinator of Kasaragod CAFOG Oncology Committee. So welcome, Maya madam. I request Elizabeth Madam to introduce our speaker for the session, Dr. Mumtaz P.
Rajesh, it's fine. I think CV slide is up.
Yeah, is Elizabeth Madam here?
Yes, yes, I'm here.
Yes, madam.
Yes. Dr. Mumtaz, happy to introduce you. And she is professor in the Department of OBG in MES Medical College, Perindalmanna. She has been my senior in college and a very good friend of mine. She has, from her PG time onwards, she has been very active in academics. And she has bagged the Kalyanikutti Amma Memorial Gold Medal in All Kerala. And she has had many other gold medals like Dr. Tamban Memorial Gold Medal also in All Kerala Conference and Amendranath Dan Prize for the best MCH paper in AICOG. Welcome, Dr. Mumtaz.
Thank you. Thank you, Patel sir and Asha madam, for this wonderful opportunity to be with you all today. And thank you, Shekhar sir, for joining from there and telling few comments about me. Thank you for those nice words, sir. Happy to see all my friends from across Kerala here. So good evening to the chairpersons. Shall I share the screen?
Oh, yes.
Okay.
You may share the screen, your co-host.
Can you see the slides?
Yes, ma'am.
Okay. So today we are going to talk about rupture of the uterus, the diagnosis and management. The first thing that comes to our mind when we think about rupture is that it is a condition with high maternal and perinatal mortality. Another important aspect is that it can occur anytime during labor or delivery and sometimes even in antenatal period. So by definition, it is when the walls of the uterus break. That is dissolution of uterine walls anytime after 28 weeks of gestation, with or without expulsion of the fetus. That is endometrium, myometrium, and perimetrium. When all these walls are broken, it is called rupture. So it may be just a rupture with the fetus still inside the uterus, or after the rupture, the fetus can sometimes escape into the abdominal cavity and the uterus can shrink, contract, and there may not be any hemodynamic instability. I've heard of stories of patients who are walking around in the ward, grand multiparas, and actually they had a rupture and then suddenly they collapsed. So whenever we think about the causes, why there should be a rupture, the first thing that comes to our mind is a cephalopelvic disproportion, where a fetus is trying to come out of the pelvis, but it is not able to do. And the strong uterine contractions are actually pushing it from above, and there's an obstruction in the lower part, and the uterus has no other way other than giving way. So the causes may be obstructive causes because of cephalopelvic disproportion, neglected shoulder, which sometimes happens in an undiagnosed cases. Hydrocephalus, again, we may think that it is easy to diagnose hydrocephalus, need not be, especially if there is not a term scan available. So some anomalies, conjoined twins, and even otherwise twins can sometimes lead to, when it is both cephalic, that itself can lead to some obstruction and can lead to rupture of the uterus. There may be traumatic causes, which is usually associated with the maneuvers that we perform, like internal podalic version, breech extraction, and due to oxytocics, and sometimes due to injudicious use of instruments in labor. Third variety is scar rupture. It need not be a previous cesarean scar. It could be a previous myomectomy scar or after resection of cornal pregnancy, which may not be documented well also. Maybe it is documented just as an ectopic pregnancy, which is actually a cornal pregnancy, and previous metroplasty, which is done for a bicornate uterine correction. So any condition where there is a scar in the uterus, it is prone for rupture. So the spontaneous rupture or some causes during pregnancy where the uterus is actually relaxed, there is no contractions, but still suddenly the uterus gives away. This happens sometimes when there is past history of dilatation, curettage, or manual removal of placenta, where there may be an undiagnosed previous perforation during DNC or hysteroscopy, grand multiparity, following abruption when there is a cochlear uterus, congenital malformation of the uterus, and congenital fetal abnormalities. So and collagen disorders, all these can cause a rupture even if the patient is not in labor. So basically, the causes in labor are due to disproportion or uterine hyperstimulation, intrauterine manipulation, when there is forcible dilatation. That is a practice some people do when the cervix is about 3 to 4 centimeter. They try to dilate it further, which I don't know why it is being followed. We can actually wait for the usual usual progress of labor to happen. This forceful dilatation sometimes lead to a small cervical tear, which can later extend to the lower uterine segment and cause a proper rupture of the uterus. A weak scar, as we have already seen, an improper instrumental delivery, which I have highlighted because this is a very important aspect which we all should keep in mind when we do an instrumental delivery. So in this picture, we can see the uterus is ruptured, the amniotic sac is seen. It looks all green. Maybe the baby is deeply asphyxiated with grade 2 meconium stained liquor. And this looks like a scar rupture, where some part is extended to the lateral aspect also, but it is confined to the lower uterine segment. But here, it is totally different. This is a lateral wall tear, and there's also another one in the fundus. Maybe it has happened after a prolonged labor or an instrument delivery, we do not know. So, and that is in hysterectomy specimen. So incidence is about very less, 0.05 of all pregnancies, but 0.8% after previous cesarean section and more than 5% after a classical cesarean section. But what is the scenario in developing countries? As we have already seen, in developed countries, the incidence is less, but in India, it could be 0.6 per 1,000 births. And in the developing countries, the usual cause or the major cause is not the scarred uterus. It is the unscarred uterus. And it could be, the incidence could be something like 1 rupture in 10,000 to 25,000 deliveries, which I would say is quite a big number. And why it is more, why unscarred uterine rupture is more in our country or in developing countries, because there may be a difficulty in managing a case of obstructed labor or instrumental delivery and cesarean delivery may not be readily available. So people wait for patient to strain or some fundal pressure, some injudicious use of oxytocin because they don't have an anesthetist in the afternoon, or the theater is not available. All this will make one resort to some, I would say, not so non-medical methods of managing a labor. So during pregnancy, the scar that gives away is usually a classical cesarean scar. And during labor, both classical and LSA scar can give away. And the scar, maybe there are 2 words that we should know. One is dehiscence and rupture. In scar dehiscence, there is the amniotic membrane is intact. It is not given way. But in uterine rupture, scar rupture, the whole length of the scar in the whole thickness is given way. The membrane is ruptured. There is a connection between the uterine cavity and the peritoneal cavity. And because of this complete rupture, the baby can pass through the rupture to the uterine, to the peritoneal cavity. And this complete rupture will definitely lead to later on, separation of the placenta, and perinatal asphyxia or death can happen. So what is TOLAC or TROLAC, trial of labor after cesarean section? Because there has been a great increase in the cesarean section rates since 1970s, and all of us are trying to decrease the cesarean rates because of the complications following repeated cesarean section, like previous 2, previous 3, previous 4. They are just increasing. The number is increasing, like in some Western countries. Or so after each cesarean, there is a risk of additions. There is a risk of placenta accreta spectra. So where to put a checkpoint? Prevent the first cesarean. If the first pregnancy or first delivery is cesarean, usually the following one is also a cesarean. So to decrease that number, TOLAC came into existence, that is trial of labor after a cesarean section. So if it is successful, if a woman delivers after TOLAC, vaginal birth after cesarean section, if it happens, definitely we know the morbidity to the mother and fetus is much less than a scheduled cesarean delivery. This is better for the mother and the fetus, no doubt about it. But if it is unsuccessful, according to the ACOG bulletin 2019, a failed TOLAC, when it ends in cesarean delivery, the associated morbidity is much more. So, among the complications of TOLAC, uterine rupture is the major one, and maternal mortality can happen approximately at a rate of 1 in 500 uterine ruptures. But again, it depends on whether it is diagnosed early, whether it is managed promptly, whether blood and blood products were available. So it's a multi-system management. So the mortality and morbidity depends on many factors. So classification is complete rupture, as I've already told, or incomplete rupture where the visceral peritoneum is intact. And based on the site, it may be in upper segment or lower uterine segment. Coming to the signs, if the patient is in labor, there is cessation of pain and contractions. The contour of the uterus, the piriform shape or the longitudinally distended uterine ovod is lost. The fetal parts becomes easily palpable. FHS is lost. And if the fetus is escaped from the uterus, there can be a swelling, which is actually the contracted uterus in one of the iliac fossa, with the uterus on one side and the fetus on the other side. And when we do the vaginal examination, imagine the head was at -2 or -1, then suddenly we feel the head is above the brim. It has lost the station, just moved to a higher station. Bleeding PV will be there, maybe there hematuria happens when the bladder is involved. And of course, when anything of this sort happens, the patient will have tachycardia and will have hypotension and can go into shock. So monitoring a woman in labor is very, very important. Not the contractions alone, not the FHS alone, not the progress of labor alone, but the vitals also. And this can also present as sudden collapse. Suddenly the mother can collapse. And there we have two important differential diagnoses of amniotic fluid embolism and abruptio placentae. Is ultrasound used? Many of the time ultrasound is not required. It is a clinical diagnosis. But if there is a doubt like this is scar days, and sometimes we can do an ultrasound. And if they're in ultrasound, what is seen is if there's a rupture is complete, there will be hematoma, intrauterine blood, free blood in the peritoneal cavity. The uterus may be empty. The sac above the uterus in early pregnancy, large uterus mass with gas bubbles because of the rupture. Here you can see on left side is the uterus and here is the fetal part. And here this arrow shows there is a defect in the uterine wall. And here, this is the amniotic sac which has herniated through the defect in the uterus. This is again a defect in the uterus through which the amniotic membrane has protruded out of the uterus. So treatment basically has many aspects. First, we have to resuscitate the patient and do the laparotomy. It is not a stepwise, it is always together. Resuscitation and laparotomy has to go hand in hand because the immediate thing is to prevent shock from happening and to prevent further bleeding. That is, you have to stop the bleeding. For that, you have to do the laparotomy. And postoperative care is also very important. So the surgical options mostly is hysterectomy, unless it is a scar rupture, a clean-cut incision like a cesarean incision, if the scar is just given way, where we can close the scar. But when you usually repair the rupture, we also advocate for a sterilization because in this case, she has a tendency for rupture in the next pregnancy also, which can happen even before she gets into labor. So if a patient is not willing for sterilization, it has to be clearly documented in the discharge summary and her case sheets, and she has to undergo an elective cesarean section, maybe around 36 weeks of gestation. And usually it is a total hysterectomy that is performed, and in some situations where we are not able to, especially after a prolonged labor, if somebody goes for a rupture, it may be very difficult to identify the cervix, and it is all dilated. Cervix and vagina is like one continuous funnel, and we may not be knowing finally what we get to do is maybe at subtotal hysterectomy. And if it is a placenta perpreta, the more severe variety of PA spectrum, what we end up doing is a classical cesarean section with hysterectomy, obstetric hysterectomy. So here you can see this is a repaired scar. This is a lateral wall scar where hysterectomy was done. This is again a lateral wall tear, but obviously hysterectomy is not done, it is repaired. This you can see there's a cesarean also. This is a lower segment also. Maybe a lower segment scar is given way, and there was also an extension, very, very long extension upward. Here you can see the placenta perfida coming through the uterine wall. And in this case, as soon as we open the abdomen, we can see there is blood. And actually the placenta and the fetal parts, fetus is inside the peritoneal cavity. And behind that is the uterus with a large vertical tear in the anterior aspect. So here is another case where repair was done, but there is a, as you can see, there is a bladder injury or bladder dehiscence involved with this case, and a suprapubic catheter was installed. So it may not be just a obstetric hysterectomy or a repair of the rupture. We may have to deal with a bladder tear which has extended during the rupture or which has happened during our repair process. Anything is possible. So we have to keep in mind that such things are also there to deal with. The overall mortality is about 16% with a very high perinatal mortality, which can be about 56%. So when we come to the treatment proper, we should always tell the relatives about the condition, and because this is not an elective thing, this always happens as an emergency, something like an amniotic fluid embolism, but in a lesser severe variant, because nobody is expecting the woman to have a rupture during labor. The maximum they might expect or anticipate, okay, if she doesn't deliver, she may require a cesarean section. And suddenly we have to tell the relatives that the uterus is ruptured. And sometimes we may have to do the hysterectomy. Baby may be already dead inside, we do not know. Or maybe it is deeply asphyxiated with the consequences it may have to face in the NICU and in the neonatal period. Even sometimes later in life, maybe it is compromised for life, we do not know. And the mother will definitely require intensive care support or sometimes ventilatory support also. And baby, if born alive, because of the asphyxia and the related complications, it is going to require a prolonged NICU stay. So immediately we need to have people around us. If you're alone in the labor, which is a very difficult situation to handle. If oxytocin is on flow, we have to stop it. Put another cannula, also a large bore cannula, like how we manage PPH, airway and oxygenation has to be maintained. Immediate arrangement of blood should be tried, but meanwhile, we should maintain the intravascular volume with crystalloids, colloids, and immediate laparotomy has to be carried out. Post-operatively, thromboprophylaxis is very important. It's a surgery which takes a lot of time. And we are dealing with a lot of tissues in the pelvis, especially the woman was in labor with all the hyperemia and all the uterine contractions. Maybe the uterus itself was thick with the edematous. Many factors are there which will make this woman more prone for thrombosis. She should get proper IV antibiotic broad spectrum with both negative and positive cover and anaerobic cover. Following recovery, definitely she requires counseling because maybe she is having only one child, second pregnancy has ended in a rupture and she has lost the uterus. Imagine the plight, and maybe the baby is also sick. So that psychological counseling is very important. And contraception, if it is a repair, again, contraception and spacing is very important and should be advised. So in this case, what is awaiting us when we have a rupture is definitely hypovolemic shock, which can progress to a DIC, disseminated intravascular coagulation, and the woman is more prone for sepsis because she was in labor for a prolonged time, and definitely the risk of thromboembolism. And mental shock is very, very severe both for the patient and the relatives. And we know about all how the bystanders get agitated even with a small complication or side effect. So we should always be prepared for all that, and the litigation and our paper should be perfect. So this watchful expectancy and timely interference, the balance is not always met. Proper monitoring is important. There is no question of missing a transverse slide or a mentor posterior or a CPD. Among the three, I would say CPD is the most difficult thing because sometimes we see, okay, it's average size baby, average size baby, which is small gynecoid pelvis. Sometimes that's how we write the pelvis. It is not that typical contracted pelvis, and that gray zone will give us trouble. So prevention is how we select the cases for Trolac. Proper selection should be there. And avoid uterine hyperstimulation. Don't give back-to-back misoprostol. Don't do ARM and immediately oxytocin. Give time. At least 4 to 6 hours after the last dose of misoprostol to start an oxytocin. And after ARM, give 1 or 2 hours to start an oxytocin and vice versa. So that is very important. Don't hyperstimulate the uterus. They should follow the protocol for induction of labor, judicial use of instruments, and meticulous selection for ECV, proper monitoring of labor. Now we have all this LDR, labor, delivery, recovery. It can also be labor, cesarean recovery. Don't tell your patient, oh, you are going to deliver, I'll make you deliver. All those days are gone. Our aim should not be fixed like achieving vaginal delivery. Our aim should be a safe mother and a safe baby. So delay in progress is something, but it is not a part. We are not, all of us are not following a partograph. Maybe in an institution we are following, some people are following. Otherwise, even by looking at the proper monitoring of the uterine contractions, descent by per-abdominal examination, you can feel the fetal pulse, whether it is palpable at the same level or it is going inside. Slow dilatation, all these are things that should tell us that we have to reassess this case, whether to give this patient more time or not. And asynclitism, uncorrected asynclitism and irreducible molding and large caput are definitely warning signs which require a reassessment. Problem with these things are that they will give us a falsely low station of the head. It will appear uncorrected asynclitism or a large caput. We will think that head is below +1 or +2, but it is actually a large part of head is still above the pelvic brim. Warning signs could be very strong contractions, patient is dehydrated, bladder is pulled up, bowel loops are dilated, and there can be abandonment. These are warning signs where we shouldn't prolong any further. Hematuria, fetal distress can be there. It may be a fetal tachycardia in the beginning and later on can lead to bradycardia. We have to reassess and act quickly before maybe it goes into severe fetal decelerations. And one word about instrumented delivery. Don't forget about these things which can give you a false low station. So always palpate, like how we have learned during our MBBS and PG days, the second pelvic rib. Palpate with both hands during the uterine relaxation period and look for fetal pole. If fetal pole is palpable per abdomen on both sides, we should not use instrument. The instrument can be used only if poles are not palpable per abdomen, and we have to follow the direction of pull according to the curve of Caras. Otherwise, we might end up in rupture of the uterus. If the head is still up, one portion of head is still up, and we try to pull it with a forceps from below, the head might come along with that, the distended lower segment will tear. What is the role of UST for prediction? What about the thickness of the lower uterine segment? Somehow we are all asked for the scar thickness when we send these women for our third trimester ultrasound. Studies have shown that if the thickness is less than 2.3 millimeter, there is a more chance for uterine rupture. A recent study from China said that they did the measurement the first trimester and third.
Excuse me, ma'am, Mumtaz ma'am.
Yes.
You need to wind up, please.
So the actually I didn't know about the timing matter. Sorry.
It's
so,
20 minutes, ma'am.
Okay. So without uterine rupture, it was 1.6 and with it was 1.1. So another important thing is in first trimester, we can always look for the niche, uterine niche, which has, if it is more than 2 centimeter, there is a more risk for uterine rupture. Look for a uterine niche in the first trimester following a case of previous cesarean section. So to summarize, monitor these women properly, look for signs of cephalopelvic disproportion, monitor the fetal heart rate, and ultrasound may not give us all points whether it is safe to keep for Trolac, but proper selection based upon the previous cesarean details is very important, and judicious use of instrumental delivery. will save many women from unwanted complications of rupture uterus. Thank you.
Thank you, Mumtaz madam, for that nice session on uterine rupture. I think you could cover almost everything. As you told, CPD is a big question mark. Whenever sometimes we feel that she may deliver vaginally, she may not, even after giving for a long trial. Sometimes when we feel she may not deliver vaginally and we about to decide for a cesarean section, suddenly she'll become full and the head will come down and she'll deliver. It's really tricky. So, but as you told, if you are monitoring properly in the labor room, we can catch the signs of patient going for uterine rupture, especially in multipara. Primi, I think we can give prolonged trial for labor, but for multi, I think it's better to take early. And cesarean section, again tricky. Previous LSCS, whether to allow for vaginal delivery or not. Even sometimes when the uterine scar thickness given by ultrasound, we can't rely on that completely. Anyway, it was a very good session and you could cover everything, entire whatever necessary for uterine rupture. Thanks a lot, madam.
Thank you. Thank you.
Thank you, Mumtaz ma'am. We have one comment on YouTube that it's very, very informative and good.
Thank you, madam.
So, sir, may we start the panel because we'll have to end it at 7:30.
Yes,
we'll have to end it.
Yes.
So, welcome to this panel on MTP Act and its amendments. For this, the expert in the line of fire is Dr. MC Patel, sir, because this is a reverse panel where the panelists are going to ask questions and I'm going to coordinate both things. I would like to read out the CV of MC Patel, sir. I know he doesn't need an introduction, but it's a pleasure to read it and remind ourselves. Sir is a consultant, obstetrician, gynecologist, and medico-legal counselor. He was VP Foxy 2018, Organizing Secretary ICOG 2017, Chairperson, Ethics and Medico-Legal Committee Foxy 2011 to 13, Honorary Secretary SOGO 2022-24, Organizing Chairperson MMCon, Honorary Member National Inspection and Monitoring Committee PNDT Act, State Supervisory Board PNDT Committee Gujarat State, President of Gujarat, and many, many more things. More than this, I would like to tell everyone that Sir has consistency and approachability as his second name. This program is 198 and he's been doing it consistently for 3 years. Then for the past 21 years, he has been going to the Northeast to provide health care to underprivileged women. The election is 1st August 24, 10 a.m. to 5 p.m. 10th August. So please vote. And here is a short vote appeal from Sir.
शुभं करोतु कल्याणं आरोग्यं सुखसम्पदम्.
Respected seniors and dear colleagues, serving Foxy for years together, on this auspicious day, with folded hands and down head, I seek your guidance, blessings, and support to endorse my candidature for the post of Foxy President, year 2026, election year 2024. Consistently working for Foxy and trying to visit even a smaller societies and to assist our common Foxyian friends in any given situation, I have tried to serve Foxy. I assure to serve Foxy in the same way with the same zeal and enthusiasm. पथ का अंतिम लक्ष्य नहीं, सिंहासन चढ़ते जाना, लिए सभी को साथ, आगे है बढ़ते जाना.
So now I would introduce our panelists as they come along. But before that, to introduce the session, I would like to ask Sir, what was the need of this act? Why did the MTP Act come along? Patel, sir?
Yes.
Yes, sir. What was the need of the MTP Act and why was it brought?
So before this MTP Act enacted in 1971, to terminate pregnancy was a criminal offense and both were considered guilty, patient herself and person who was doing termination of pregnancy. And due to that, people used to go to quack or untrained person for termination of pregnancy. And there were so much high mortality related to these abortion services. And that is why government formed a committee, Santilal Shah Committee. It was formed in 1966. And that committee came up with report and recommendation rather. And in 1971, MTP Act was enacted. Some amendment came in 2003 and then in 2021. But in that Santila Shah committee, 50% members were doctors and rest of the doctors were influenced by doctor. And I am happy to announce one of representative from Foxy was also there in that very committee of Santilal Shah committee. So this committee came up with this report and this act enacted.
So we have Dr. Vidya Nambiar ma'am, who's the president of Kasargod Obstetric Gynec Society. Over to you, Vidya ma'am. Requesting anyone from
Kasargod.
Kasargod, would you please take this question?
I am Dr. Lakshmi. Am I audible?
Yes, please. Welcome, Dr. Lakshmi.
Thank you, ma'am. Thanks a lot. Sir, what are the important provisions of the Act? And was there any punishment included in the Act?
The two main provisions are place where MTP can be done and person who can terminate pregnancy. So as far as place is concerned, any government hospital or aided by government or any establishment recognized by government or district level committee. So there MTP can be done. Person who is registered medical practitioner as per Indian Medical Council Act and who is registered in respective state council and who is having experience and experience required as per gestational age of pregnancy is eligible person to terminate pregnancy. So if person is not qualified, even at registered place, if pregnancy is terminated, there is a provision of imprisonment not less than 2 years and it may extend up to 7 years. And same way, if person is qualified but place is not approved, then also the same punishment is there, 2 years imprisonment up to 7 years of imprisonment. So we should be careful as far as MTP services are concerned.
Thank you, sir. Now, this question goes to Dr. Lakshmi herself, who's a graduate from Mumbai, PG from Coimbatore, and she has a Fellowship in Obstetric Gynae Ultrasound from Mumbai, Fellowship Gynae Laparoscopy from Bangalore, was working as assistant professor at GMC Kannur, and is working right now as consultant OBG at Deepa Nursing Home, Kanagar, Kerala. So over to you, Dr. Lakshmi.
Yes, thank you, ma'am.
Please
The
take
question
one
is-
question at a time.
Yeah, thanks. Okay. How effective was the initial act in its purpose for decreasing unsafe abortion, sir?
Naturally, I just mentioned prior in when this act was enacted in 1971, before that, it was criminal offense if anybody terminates pregnancy. So even qualified person cannot terminate pregnancy in those days. And due to that, people were choosing some quacks or any Jola chap doctors, and they ended into criminal abortion and ultimately with big morbidity or in few of the cases mortality also. So after this act is enacted, now abortion is safe, abortion is legal, abortion is confidential. So if it is, and in government hospital, it is free. So when it has become legal, patient have access to approach a registered medical practitioner or any experienced person who is eligible to terminate pregnancy. So due to that, this morbidity and mortality part has checked. So it is the effect. Next.
You're muted, Dr. Lakshmi. Dr. Lakshmi, you're muted.
Sorry. I'm so sorry. I'm so sorry.
Yes.
So when we mention unsafe abortion, we are talking about people who are unqualified to do abortion, isn't it? Perform abortion. Sir, empty pill, that tablet, that unwanted tablet, that is very freely available at the pharmacies.
We will discuss it later on. We will stick to this question only. So you have to ask the question number 2.
Yes, yes. How many times was it amended, sir, and why, sir?
So first, this act, which was enacted in 1971, was amended in 2003. And in 2003, district level committee was formed. So as far as registration part is concerned, previously one had to apply to the state government for registration of center. But now those power have been given to district level committee. So one can approach district level committee, and district level committee grants the permission to register the center. And one more amendment came in 2021. There are so many amendments in this, and very important amendment to mention that failure of contraception, it was available to married woman and her spouse only. But with this amendment, now it is available to any woman and her partner. So irrespective of her marital status, now failure of contraception is available indication up to 20 weeks of pregnancy to terminate pregnancy. One more amendment came. Previously, pregnancy up to 20 weeks were allowed to be terminated. Up to 12 weeks with opinion of one person, and 12 to 20 weeks opinion of 2 registered medical practitioners. Now with this amendment, up to 20 weeks of pregnancy, opinion of 1 registered medical practitioner is enough, and after 20 and less than 24 weeks, 2 registered medical practitioner can opine. But there are some 7 conditions given with this amendment. So in those 7 conditions, one can terminate pregnancy more than 20, less than 24 weeks with opinion of 2 registered medical practitioners. More than 24 weeks of pregnancy with opinion of medical board, one can terminate pregnancy. So these are some good amendment in this 2021 amendment. And one more, as far as confidentiality of patient is concerned. Previously, it was also there. But with this amendment, punishment made stringent one. Because in case of breach of confidentiality of any patient who has undergone MTP, there is a provision of 1 year of imprisonment and fine of rupees 1,000 or both. So with this amendment, it is included.
Thanks, sir. That was very enlightening. What was the latest amendment, sir?
As just I mentioned, in 2021 it came, and all these amendments came. Pregnancy allowed to be terminated even more than 24 weeks with opinion of medical board.
Yes.
This is the latest amendment.
Yes, sir. How does it benefit the women and doctors, the latest one? Sir has already mentioned.
Naturally, few were the congenital anomaly which were not detected till 20 weeks of pregnancy, and many a time it is detected after 20 weeks. So now in those conditions, if those congenital anomalies are incompatible with life of fetus, those pregnancy can be terminated up to 24 weeks with opinion of 2 registered medical practitioners. And if it is more than 24 weeks, then with opinion of medical board, pregnancy can be terminated. So it is in good faith of patient. And one more benefit to the woman, once case is before medical board is under obligation to opine within 3 days. So within 3 days, if permission is granted by medical board, then that very pregnancy should be terminated within 5 days. So these two good amendment came in 2021. Opinion from medical board within 3 days and termination of pregnancy within 5 days. Because in past, what was happening, before more than 20 weeks, one had to rush to Honorable High Court seeking writ petition for termination of pregnancy. And High Court were referring patient to medical board, but time limit was not there. So in one of the cases it was happened, and it was published in a Hindu newspaper, that opinion was asked at 24 weeks of gestation. And when opinion came, pregnancy was 36 weeks of pregnancy. So not to end up into this type of issue, in this amendment, it is made very much mandatory for medical board to opine within 3 days and to terminate pregnancy within 5 days. So this is good amendment in favor of patient.
It's very useful, sir. Even for the doctors, it will be very useful.
Even for doctors also, but for patient, it is blessings.
Yes, sir. Yes, sir. True.
Yes.
Thank you, sir. And now we have Dr. Bhavya AB, who's a consultant at Aster MIMS Kannur, visiting consultant Nucleus Hospital Kannur, and secretary of Kannur Obstetric Gynec Society. Welcome, Dr. Bhavya.
Thank you, ma'am. Thank you, ma'am. Thanks for this opportunity. Very good evening to all. So, what are the violations of the Act commonly seen in the court? Am I audible?
Yes. If pregnancy is terminated at unregistered place, or if pregnancy is terminated by unauthorized person, so this is main violation of Act commonly seen in court. And one more, one who has not complied with the provision of MTP Act 1971 and this amendment, then also it becomes a area for litigation.
Okay, sir.
Say for example, consent is to be taken in Form C, and if consent is not taken in Form C, then it becomes a point for litigation. Opinion is to be formed on record. If opinion is not formed, or if records are not properly maintained, so these are some areas as far as litigations are concerned in court.
Okay, sir. Sir, are medical abortions also covered under the Act?
Yes, naturally, yes. Because it is one of the method of termination of pregnancy. So by whichever method you terminate pregnancy, it comes in purview of MTP Act.
Okay, sir. So what are the forms to be filled and the provisions of personal privacy of the lady under the Act?
So as far as different forms related to MTP Act is concerned, so let us start with A. Prescribed Form A is for application for registration of center. If registration is given, then certificate of approval is given in Form B. Form C is form of consent. So consent is to be taken in Form C only. Because if you have not taken consent in Form C, then you may lose shelter of provision of MTP Act, and you may be triable under Indian Penal Code and now newer version. So old section, Indian Penal Code, section 312 to 316. So it is very much mandatory to terminate pregnancy under provision of MTP Act. So these are some provisions, forms are concerned. One more form is Form D. So this is form for medical board. Medical board will opine in prescribed Form D. Form 1. Form 1 is opinion of registered medical practitioner up to 20 weeks of pregnancy. One more form is Form E. When pregnancy is more than 20 and less than 24 weeks, then opinion by 2 registered medical practitioners are to be formed in Form E. Form 2, it is monthly reporting form. So at the end of month, you have to report to appropriate authority about all your cases happened in last month. But at the time of reporting, we should be careful. No personal identity of any patient is to be revealed in this Form 2. It is very much required. So we should observe that. So as far as confidentiality is concerned, we have to strictly observe confidentiality of patient. Otherwise, just I mentioned, there is a provision of 1 year imprisonment. So we should be very careful. Form 3. Form 3 is form of admission, or we may call it MTP register, whichever we call. So all the information of patient who is undergoing MTP are entered in Form 3 and number is given to that very patient in Form 3. And then after, all the correspondence related to that very patient should be with number given in Form 3. Say for example, in OT register or in discharge card or in any other area, wherever you have to mention, then you will go with number only and no name of patient will be mentioned. So that is Form 3. So these are some forms as far as MTP Act is concerned.
Thank you, sir. Now we have Dr. Lakshmi S., who's an additional professor, Department of Gynae, Government Medical College, Kozhikode, President, Calicut Society, immediate past President, Calicut Menopause Society, VP, Calicut Obstetric Gynae Society in the past, and has many awards and fellowships. Welcome, Lakshmi ma'am.
Good evening, sir, and good evening, Dr. Asha. Good evening, everyone. Am I audible?
Yes, madam.
Yes, ma'am.
Yeah. So, who can be shown the documents of the lady, and who's the authority on whose orders papers are to be shown?
So as per MTP Act, this MTP register just I described, all the information is in that register, and that register cannot be opened in usual manner. There are only 2 conditions in which that register can be opened and all document one can verify. One, if patient is working woman and if she is interested to have certificate to grant her leave from her job, then one can open this register and from all the data one can prepare certificate and give it to patient. And second provision is under authority of law. Person who is authorized by law can inspect all the documents related to patient undergoing MTP. And in this, Chief District Medical Officer is appropriate authority. Of course, it person could be different in different state, but usually Chief Medical Officer is there. So these are the provision as far as document inspection is concerned. If there is a litigation and if any investigating officer comes, then he is under authority, he can also inspect register. But in this time, we have to identify the person because many a time fake person come and all the confidential information may be given to that fake person. So we have to identify that person under which case he is investigating, and you can ask from him or her in writing and copy of FIR of that very case also.
Thank you. Now, since we are in the habit of maintaining registers and since this has to be reported to the district authority, how can we ensure privacy as you have quoted earlier?
When we inform district authority, it is prescribed form, that is form 2. And in form 2, you have to go with only statistic. No personal identity of any patient is to be revealed in form 2. Say, for example, how many MTP occurred in your hospital in month of June, you will write 20. How up to 6 weeks, 4. How up from up to 12 weeks, say for example 10. More than 20, 12, less than 25. That way we have to go with statistic only. No personal identity of any patient is to be revealed in that very form. And then you can very well upload online, or you can send physical copy, whichever the system in your state.
Okay, so that sounds reasonable. Now, as Dr. Lakshmi, the previous questionnaire had asked, doctor had asked, with the availability of MTP pills over the counter, where does the reporting on MTP stand?
So, when patient comes to you with any complications and patient gives history that she had taken abortion pill over the counter, if patient is willing to lodge complaint, that complaint can be lodged against that very pharmacy or person who had supplied OTC over the counter and who is not authorized to prescribe or supply this drug. But many a time, whenever patient has taken medicine from pharmacy has not issued any bill. So it becomes difficult in court of law to prove that medicine was given over the counter from pharmacy. As far as selling of this type of drug over the counter can only be restricted by Food and Drug Department, because all the pharmacy comes under Food and Drug Department. So if Food and Drug Department becomes strict, then only it can be stopped. Because Food and Drug Department can ask information of pharmacy, how much medical pills you purchase in that very month, how many MTP pills sold, and against which prescription it was sold. And they may have counter inquiry also. Say, for example, that pharmacy gives information that I sold this medicine against prescription from Dr. Siva Kumar. Then he may go to Siva Kumar, did you prescribe this medicine to this patient? If it is yes, fine. If it is no, then action can be taken against pharmacy also. But in this situation, we should be very vigilant enough to prove in court of law, because with lack of all the evidences, it becomes many a time difficult to prove in court of law that pharmacy had sold that very medicine over the counter without recognized prescription.
So, do we have to give 2 prescriptions for such patients when we prescribe MTP pills, so that one is kept with the pharmacy as a proof of prescription of the doctor?
Yes,
and
we can prescribe 2.
One is kept with the patient.
Even if we have prescribed 1, but when he issue receipt, in that very receipt, I mean bill, in that very bill, name of doctor is to be written.
Okay. And if supposing such a patient takes the the pill over the counter and she comes with retained products.
So now it is a case of complication of pregnancy. So it doesn't come in purview of MTP Act. Of course, we have to treat that very patient, whether she comes with retained product or incomplete, missed abortion or any other complication related to that. We have to treat that very patient. We have not to go for any formality of Form C, Form 1 or any other form. And we will treat that very patient usually as we treat other patients. So with informed consent and all the details. But at the time of taking history, if patient gives history of taking medical pills over the counter or prescribed by some quack, we have to mention in that very history. And if patient is interested to lodge complaint, then we can inform this.
So does that also come in the register? Do we also have to put it as a case of
Not at
MTP?
all. No form 1, no form C, nothing, because it is a complication. And any complication of pregnancy when you are dealing with, they do not come in purview of MTP Act. And it was clarified in 2012. One RTI happened. And in that very RTI, the same questions were asked. So in RTI, it was clarified. So no need to go for any formality related to MTP Act in this type of complication of pregnancy.
Thank you very much, sir.
Yes.
Thank you, sir. Sir, you'll have to be really fast because we have 8 panelists and we have 20 minutes only. So we have Dr. Kochumani, ma'am, President of Perithel Manna. And ma'am, are you there? Or I would request Kalpana, ma'am, to take the question, please. Ma'am, you are muted.
Yes, Dr. Kalpana.
Good evening, sir. Sorry, I got some network issue. That's why I couldn't attend. Am I audible, sir?
Oh, yes, you are audible.
Ma'am, yeah. So, who gives consent?
Zoom user is written. Who is that?
Pardon, sir?
Ma'am, would you please rename?
Am I audible, ma'am?
Yes, yes. Kalpana, you are audible.
Yeah, sir. When lethal deformity is detected in anomaly scan, can MTP done till what weeks?
Yes, it is allowed indication. Pregnancy up to 20 weeks. When lethal deformity is detected, then pregnancy can be terminated with opinion of one registered medical practitioner. If it is more than 20, less than 24, then with opinion of 2 registered medical practitioners. And if it is more than 24, then opinion of medical board. But in lethal deformity, termination is allowed.
If there is non-lethal anomaly at 27 weeks, can we proceed with MTP, sir?
So when pregnancy has advanced 24 weeks, you have to go with opinion from medical board. And medical board is conferred power only to opine in case of congenital fetal anomaly which are incompatible with life of fetus. So in non-lethal anomaly, when pregnancy is more than 24 weeks, medical board will not opine. And once medical board doesn't opine, then you cannot terminate. And in this case, if at all patient is interested, then patient can seek permission from Honorable High Court seeking writ petition.
Who can consent to do this? Who is allowed to do MTP in this case?
So in this case, if there is a opinion from medical board or opinion from Honorable High Court, then any registered medical practitioner who is authorized to terminate pregnancy at registered place, pregnancy can be terminated.
Okay, sir. Thank you, sir.
It is not necessary that when opinion is from medical board, that very pregnancy should be terminated in medical college or district hospital only. It is not like this. It can be terminated in private sector also, but for that very center should be registered or eligible to terminate pregnancy at any given gestational age.
Okay. Usually what happens here, whenever they come across the 20 weeks, we are sending them to medical college, sir. That to government medical college.
No, as such, it is not at all required or not at all necessary. One can terminate pregnancy. Because if your center is registered to terminate pregnancy more than 24 weeks or more than 20 weeks, you can terminate.
Okay, sir. Thank you, sir. Thank you.
Yes, next. Asha Jain, madam.
Question is Suma, madam. I think some problem with Asha madam. She's screening.
Achha.
Yes, she
So
has
till
logged
till
out, I
till
think.
then,
I'm
Maybe some
back, sir.
issues.
I'm back. My
yes,
phone
welcome,
actually crashed.
Yeah.
My laptop crashed.
welcome,
So,
welcome.
Lakshmi ma'am,
Hey,
Suma ma'am, Dr.
next,
Suma.
now
Jyoti
it is
Ramesh
turn on.
Chandran ma'am.
Now Dr. Suma, Dr. Suma.
No, please. What I'm saying that she has to make me host. I had made her host before I left. So Dr. Jyoti Ramesh has to make me host. Oh, okay. I'm there. It's okay. I'll share screen. Just a second. I'm really sorry for that. Means usually I'm more careful. I don't know what happened.
No, anyway, it happens.
So we are done with Dr. Kochu Mani's question. Now we are at Dr. Suma's question. So Dr. Suma, consultant obstetric gynae from Wayanad. Welcome, Dr. Suma. Here.
Thank you, ma'am. Thank you so much. Sir, good evening, sir. So my
Yes,
question for
welcome,
you
good
today
evening.
is, yes, sir. Any interesting cases with learning for us, sir, on the mistakes we need to avoid? I think that is one of the important questions for
So
today's
very
session.
quickly, I will go to that question. Person was qualified, center was registered. So he terminated pregnancy with all these requisites of Form C, Form 1, etc. But there was a quarrel in the family afterward, and patient lodged a complaint against in-laws that it was forceful abortion without my consent, against my will. So in that very case, doctor was asked to come to court to give opinion. And from that very case, court asked from the doctor to produce Form C, Form 1. But for any reason, doctor couldn't produce because doctor said that it was OPD case and we terminated pregnancy on OPD ground only. So he couldn't produce all those records. Court ordered to arrest him from the court only, and doctor was behind the bar. After 3 days, party had a compromise, case was withdrawn, and then only doctor was out of a bar in this very case. So carry home message in this type of situation is, whenever you terminate any pregnancy, you should terminate pregnancy under purview of MTP Act 1971. Because in MTP Act, very clearly mentioned that notwithstanding anything contained in Indian Penal Code or any law time being in force, registered medical practitioner will not be considered guilty of any offense if, here word is if, he has terminated pregnancy in accordance, one more word is accordance, in accordance with provision of MTP Act 1971. So if you are terminated pregnancy in accordance with provision of MTP Act 1971, then you are out of purview of IPC. So you cannot be prosecuted criminally. And that is why you should practice as per MTP Act. But not only that, you should be ready with all the documents which are very much required as per law, and you should be in a position to produce in court of law.
Thank you, sir. Thank you. And the final minimum recommendation to avoid litigation in
Plus,
MTP.
I mentioned.
Yeah, sure,
You
sir.
have
Sure.
to comply with the provisions of law.
Okay,
Yes,
sir.
welcome, Shiva Kumar.
Yeah.
So now Dr. Shiva Kumar KS, Secretary, Wayanad Society. Welcome, sir.
More than 24 weeks is done, and if the baby delivers live, to whom the custody should be given?
So this is very tricky situation. After this amendment, when pregnancy termination is allowed more than 20 weeks, it is likely that fetus may come alive. So here comes our role at the time of counseling. When we counsel this patient, we have to mention possibility of fetus coming live, and we have to mention that custody should be taken by patient and patient party. Many a time it happens that even if they have given a promise that we will take custody, they do not go with custody. So in this situation, there are some questions which are already there on the screen. Can we transfer patient in NICU? Of course you can. In government hospital, there is no problem. But in private sector, when you transfer that baby in NICU, who will bear cost of NICU? When patient is not willing, then patient will not bear the cost. One more area, is there any role of police in this type of situation? Yes. If patient has given consent at the time of counseling and giving consent that they will take custody, and if they are not taking custody, then you can inform police. One more area, can prior feticide be considered? It is gray area. So prior feticide, whether it is to be considered or not. In foreign country, it is routine that when you are terminated pregnancy more than 12 weeks, then you have to go with feticide first and then you will terminate pregnancy. In India, still it is not there. And here comes role of IMA, FOXY and all organizations to clear all this gray area with authority or with government, because authority will not also be in a position to clarify this situation. So we have to approach government on association level. And in a lighter way, I many times say, if you vote me, if I am a President Foxy, I am going to take this type of so many questions we are pertaining to us in our day-to-day medical practice. Yes, Shiva Kumar.
Thank you,
Next.
sir.
Yes.
Next, we have Dr. Umar Andhir, ma'am, Consultant Obstetrics and Gynecology at Vinayaka Hospital, Wayanad. So over to you, ma'am.
Hello, sir.
Yes, welcome.
Hello, sir. Sir, my question to you is a 26-year-old Gravida 3 Para 2 Living 2 having 22 weeks of pregnancy has come for MTP, giving a reason of failure of contraception. Can you proceed to do MTP or not, sir?
No, here pregnancy is 22 weeks and
yes, sir.
indication of failure of contraception is available up to 20 weeks of pregnancy only. So you cannot.
Okay. Okay. Thank you, sir. Thank you.
Yes.
We have Dr. Mini Balakrishnan, ma'am, who's the past president of Kannur Society. Welcome, Dr. Mini.
Good evening, ma'am. Good evening, sir.
Yes.
A 19-year-old unmarried girl was brought to hospital in shock by an A&M practicing in the periphery who did a criminal abortion at her clinic at 3 months of pregnancy, and she was accompanied by her parents. And on examination, the patient was in shock. Momentum was hanging through vagina. What is to be done?
Naturally, we have to treat patient because in law, it is very clear dictum. First, you treat the patient, all the legal formality afterward, if it is an acute emergency. So in this situation, when patient is brought in condition of shock and momentum hanging through vagina, naturally, first we have to resuscitate patient. We have to rush for laparotomy and to do all the necessary surgery, etc. And then after all the formalities. So now questions come, should we do FIR or wait for police to come? No, we have not at all to wait for any police to come. because we have to treat that very patient in that very given situation. And as far as FIR part is concerned, if patient and patient party are interested to lodge complaints against that A&M nurse, then we have to inform police. But we are informer only. Complaint will be on part of patient and patient party. They will be complained. If they are not willing or if they are not interested to complain against that very A&M, then we have not to inform police.
We have to know, sir. Anyway, because it is a criminal abortion.
It is criminal abortion, but when patient is major, when patient is mentally sound, he can, or I mean, she can take decision whether complaint is to be lodged or not.
Thank you.
Thank you, sir. Now we have Dr. Sabita Nityanand, ma'am, a very senior gynecologist from Calicut Medical College. And she sings beautifully, sir. Very, very nice.
Yes, Savita madam, welcome.
Good evening, sir. Good evening, madam.
Yes, good evening. Good evening. Welcome, madam.
Okay, my question to you, sir, is a 22-year-old unmarried girl comes to a doctor with her boyfriend and asks for the termination of a 3.5 months pregnancy. What is to be done?
So, if center is registered, person is qualified, one can terminate pregnancy because she is major, 22 years. She can give consent for termination of pregnancy. And under MTP Act, no other person is required to give consent, and only patient will give consent when patient is major and mentally sound. So in this, pregnancy can be terminated, no issue. But word of caution, because she is unmarried and there could be quarrel between him and that very boyfriend. And if at all he lodge complaint, because in few of the cases it has happened also, that police comes to you that you terminated pregnancy of that very patient on this date, and now she has lodged complaint against that very boy because he is declining of promise of marriage, and against that promise of marriage I had given consent for coitus. So it becomes a case of rape. Why you didn't inform police? That way police may try to harass you, but as such it doesn't work in court of law, because if you have taken in a writing from patient herself that it is a result of consensual sex, I have no complaint against anybody, I do not want to inform police, because at that point of time when you are going to terminate pregnancy, she was very clear. She had no complaint against anybody. Then after, for any reason, if she is going to complain against anybody, how doctor can predict that in future it will happen? So if patient has given in writing these 3 lines, you are safe in court of law always.
Okay, sir. Thank you.
Yes.
So, sir, next question was supposed to be for Dr. Bhavin Balakrishnan, who is a senior gynecologist from Calicut, but he's not here, and Vidya Nambiar ma'am has joined in. So, Vidya ma'am, requesting you,
Vidya
could
madam
you
can-
please take this question?
Oh yes. Oh yes.
Here.
Hello.
Yes, ma'am.
Thank you. Thank you, madam, for giving me a chance. I would like to ask, am I audible?
Yes, audible, madam.
Okay. I would like a 29-year-old patient conceived with ART, and it's a case of triplet with advanced advised fetal reduction. Should the center be registered for MTP, and does it come under MTP Act? And which form has to be filled in such cases?
So as
All
such,
these,
as on today, under MTP Act, it is grey area. But if we go with interpretation, word by one of MTP Act. So what is MTP Act? Medical Termination of Pregnancy Act 1971. Here pregnancy is not terminated. Pregnancy is still continued. It is only fetal reduction. So from triplet to twins or from triplet to singleton. So pregnancy is continued. It doesn't come in purview of MTP. You have not to go with any formality of any form. And you can terminate pregnancy at unregistered place. I mean, do fetal reduction at unregistered place also.
Oh.
Yes, Simi.
This is our last question. We have Dr. Simi Kurian ma'am, who's an associate professor, Government Medical College, Kannur, BP Kannur Society, past secretary of Kannur Society. So welcome, Dr. Simi.
Good evening, sir.
Yes, welcome.
Okay. Sir, my question is, a lady of 6 weeks pregnancy is coming to your clinic requesting for medical abortion. But the thing is, she is coming alone, no bystanders with her. So can we do medical MTP if she asks for it?
So as far as medical abortion part is concerned, if she is major, we can very well prescribe abortion pill to her after all the formality of Form C, Form 1, etc. We can.
Okay. Sir, but if she's asking for surgical abortion, in that
But
case,
if
can we
she
do?
wants to go for surgical abortion, then we should be very careful, because in one of the cases it was happened. She had been to hospital alone and a doctor went with surgical abortion, and there was perforation of uterus and there was profuse bleeding, blood transfusion was required, laparotomy was required. So in this situation, relative were informed, family members were informed. They come to the hospital, case was well managed, patient was saved, but relative and these family members were very angry to the doctor. Why you didn't inform prior? So if we go legally, then legally you are safe, because when patient is major, patient can give consent to terminate pregnancy. But in surgical method, at least somebody should be outside operation theater who is known to that very patient to deal with situation whenever some complications happens. Of course, we can keep all the document, etc. confidential. We can discuss only with patient. But patient will tell that somebody is outside operation theater and this is information. So if at all it is required, we can contact him or her and we can proceed accordingly. Otherwise, legally, nothing to worry. But not to end up into this type of problem in future, we should be very careful.
Thank you, sir.
Yes. Yes, next.
Thank you, sir. So now any question from anyone, or we would have to proceed to the last lecture because Lakshmi ma'am has been waiting for a long time. Jyoti Ramesh Chandran ma'am has been waiting. So any question from any panelist?
Just one short question, sir. This
Yes,
really
yes,
may
ma'am.
not be
Yes.
related to MTP, but supposing we often get cases like this, a young girl of say less than 18 years or say 17, prior to 18 years, getting legally married, becomes pregnant. She's legally married. So you
Married,
register,
not
do you
legally.
complete all formalities for POXO?
She is married only, not legally
Okay,
married.
okay. So married to the
It is considered irregular marriage in eye of law.
Pardon?
Not illegal also. Irregular marriage.
Irregular.
When she is less than 18. But irrespective of her marital status, whether she is married, whether she is not married, whether she is legally married, whether she is irregularly married, but when she is minor, and once we come to know that she is pregnant or it is considered as if she is victim of sexual offense, we have to inform police.
Inform police.
Yes. Even if she is willing to continue pregnancy, even if she is willing to deliver baby in future, then also you have to inform police.
Okay. And what follows after that? Because this is unnecessarily giving mental trauma to the couple.
That is up to police. We have to simply inform. We are informer only. We are
Okay.
not complainant. We are not complainant. What police has to do, that is up to them. Many times police close the file straight away. So they do nothing.
Okay.
But if they are interested to interrogate that very case further, they can approach patient. They can have a statement from patient, relative, that culprit, and statement from you also as an evidence. And they will lodge complaint against that culprit in court of law.
Okay.
Because it becomes a case of POXO.
Yeah.
Sir, I have a small question, sir.
Yes.
Sir, if a person approaches you for MTP And do you have the freedom of rejecting it, being a doctor?
Yes. If there is no indication which are prescribed in MTP Act, you can very well refuse to go for termination of pregnancy.
Okay.
Because in one of the case, in court it was asked, is MTP right of patient? No, it is not right of patient.
Okay,
There should be some indication which is prescribed in MTP Act. And if there is indication, then only you can terminate pregnancy.
Okay, sir. Okay. Thank you, sir.
Thank you, sir. So if you want to say a word of appeal for your vote.
Oh, yes. So, considering my seniority, sincerity, dedication, and easily availability to any Foxian friends in any given odd medical legal crisis, I humbly appeal to all of you to vote me, to support me in Foxy election 24. Election would be from 1st August to 10 August. Thank you.
I also request you to please support me for Chairperson Food Drug Committee. Please do vote for me.
So in Food and Drug Committee, Asha Jain is very deserving candidate, and in this society will vote. If society is A category, then 2 votes. If less than A, then 1 vote. And some other office bearers are also voters. Say, for example, if any chairpersons in Foxy and who is in your society, he is voter. If any past president of Foxy, he is voter. If past vice president of last 3 years, they are voter. And all the chairpersons who are just now having chairperson in Foxy, they all are voter. So if anybody from your society, they can vote in favor of Dr. Asha.
Thank you so much. So with that voting appeal completed, we start the 3rd session. And I would like to, Dr. Kalpana, would you want to introduce, sir?
Yes, ma'am.
Please go ahead.
Yeah, ma'am. Am I audible, madam?
Yes.
Yes.
I am privileged to introduce Dr. Raghavendra Prasad, sir. A very outgoing and easy, very friendly person. We always have interactions during all KFOG meetings. And he's from Sunrise Hospital, Kanjangarh. He's having a big list of achievements under him. I can tell he's a gold medalist and in MBBS, DGO, everything. And he is a regular conference participant, and he is having research and so many publications under him. If I start reading, it will take one more session to just tell about sir. So welcome, sir.
Please introduce all 3, ma'am.
Yes, sir. Thank you, madam. Dr. Vinay Chandran, sir, is a very good teacher to us. He's a professor of ONG Malabar Medical College Research Center, Calicut. He was former HOD, Government Medical College, Kannur and Manjeri. And he's a president, past president, past vice president, so many KFOG and ONG societies. He's also UG and PG examiner and excellent teacher, sir. I am also one of his students. And this is Dr. Ajit. He's President Kerala chapter of RCOG. As a fellow representative of AACEC RCOG South Zone, and he's an additional professor, Government Medical College, Trivandrum. And he's a past president of so many KFOG, Kannur, ONG societies, and also outgoing person, but he's very strict examiner, ma'am. Welcome, sir. Welcome, Ajit, sir. Welcome, Vinay Chandra, sir.
Requesting one of the chairpersons, would you please introduce Jyoti, ma'am?
I must.
Vinay Chandra, sir.
Yes, Jyoti Ramesh Chandran is a professor and HOD of Government Medical College, Calicut, and he is the president of Calicut Menopause Society and the secretary of the National Society for Study of Gestational Trophoblastic Disease, and the past president of Calicut ONG Society, past vice president of Kerala Federation, and the corresponding editor of Journal of OBG of India, and member of School of Family Health Studies, KUHAS, member of Institutional Research Committee, Kozhikode. She had 30 publications, and she's one of the invited faculty for most of the state level as well as national level conference. She had Javeri Shah Award of AICC RCOG 2021 and KFO Gold Medal for Best Paper AKCOG 2024, Best Paper Award for IMS Con. So her field of interest is wide, and she is now going to talk to us on OASIS.
Thank you, Vinendra sir,
Thank you,
for
sir.
that introduction. Respected
Raghavendra sir, if you would say a few words about OASIS while Lakshmi ma'am will share her screen. You're
Madam,
muted.
I think Jyoti madam has already started, so I think.
No, she can share her screen and you can just introduce OASIS a bit. Because I called her and asked her, what is OASIS?
Actually, OASIS is a place in Calicut.
So is my screen visible?
Yes,
yes, madam.
So
You
at
need
the
to make
onset,
it
I
full
would like
screen.
to congratulate the Happy Learning Masterclass team and Dr. MC Patel, Dr. Asha Jain for such a lovely webinar every Tuesday. And we wish them best wish for the coming election. So I would like to talk on OASIS.
Ma'am, please make it full screen.
It is full screen, not seen?
No, ma'am.
No, not full screen, Jyoti.
For me, it is full screen.
No, ma'am.
Click on this slides sharing, that big screen. It will come, madam.
Is it full
Madam,
screen?
on the bottom thing, yeah.
Is it full screen?
No, madam, not yet.
Ma'am, where your cursor is, right there, please click. Your cursor is below on a cup, on a single cup. That's where your cursor is.
I can't see it. The screen is visible. I'll go about with this only.
Okay.
Please.
Okay, carry on.
Okay. So when a woman comes for delivery, we talk about so many things. But do we really talk of vaginal tearing? That's something serious. So the OASIS is a serious complication to vaginal delivery and is the leading cause of anal incontinence, that is involuntary loss of flatus, liquid or solid stool in women. And the incidence varies between countries, between hospitals, and it is impossible to directly compare different studies because of acquisition bias. Midwives, they miss about 87% of injuries and doctors miss 28%. So we, in our practice, definitely we would have also missed so many of injuries in our earlier days. So it may occur secondary to vaginal delivery, sexual activity, external pelvic trauma, or anorectal.
Jyoti, your slide is not changing.
No. You.
Madam, on the slide share click akka, madam. Slide share click akka.
Jyoti ma'am, before you share, don't make it full screen. When you are able to see the normal view with the slides on the left, okay?
Yeah, now I'm seeing.
Yeah, keep it that way and then share and then make it full screen.
Okay, fine.
Ma'am, is it full screen on your screen?
Is it okay now?
Yes, now make it full screen.
I made it full screen. Is it okay?
Not full screen, but
And please double click and see, madam. Please double click and see. Sometimes it will work.
It's moving.
No.
Ma'am, it will not move like this. You will have to, on the left side column that you are seeing, you need to click on the next slide. Jyoti ma'am, can you WhatsApp me the slides?
Yeah, I'll do that.
If you WhatsApp it, I will do it immediately.
You can WhatsApp it, no? From this.
Yeah.
It is just like OASIS. It is difficult to diagnose most of the time.
Ma'am, did you send?
Yes, I've sent to the WhatsApp. Happy learning.
Okay, you have not sent to me.
I've sent to the WhatsApp of Happy the
That's all right, ma'am. I'm downloading it. I will share it immediately. Just a second. It will take a minute to download.
ബർത്ത്ഡേ തിരക്കിലാണോ ഇതിന്റെ വിളിച്ചതേ നമ്മളെ വീട്ടിലൊരു ലീക്ക് ഉണ്ടായിരുന്നില്ലേ ഇതാ ടെറസില് അത് താഴെ ലൈറ്റിന്റെ ഉള്ളിൽ കൂടെ ഇങ്ങനെ വെള്ളം വന്നിട്ട്
Public,
OASIS leaking. Leaking. Could you get?
Yes, ma'am, I got it. Just trying to. There. Is that fine?
Yeah.
Yes, sir.
Yeah, yes. So I was telling that it's a serious complication to vaginal delivery and the leading cause of anal incontinence. Please, next slide. And the incidence varies from country to country between hospitals, and it is impossible to directly compare different studies because of acquisition bias. It said that midwives, they miss 87% of injuries. Doctors also miss 28%. And in our learning days, definitely we would also have missed so many of these conditions. And it can occur secondary to vaginal delivery, sexual activity, external pelvic trauma, or anorectal surgeries. And vaginal delivery is the most common cause of anal sphincter injury in women. And 85% of vaginal deliveries are associated with mild perineal injury, while 10% are associated with severe injuries. The risk factors include the maternal, nulliparity, Asian ethnicity, and short perineum. And the fetal causes are macrosomia and persistent occipito-posterior position. Intrapartum, if you go for instrumented deliveries, forceps, vacuum, epidural analgesia, induced labors, prolonged second stage of labor, and midline episiotomy, shoulder dystocia. Next, please. So why should we address this OASIS? Because it causes many functional consequences such as perineal pain, acute retention of urine, dyschezia, abscess in the short term, fistulas, dyspareunia, neuropathy, and anal incontinence in the long term. Active or passive gas or stool incontinence affects on an average 39% of patients with OASIS. These injuries can have significant impact on the women as they impair their quality of life and is responsible for significant financial and psychological burdens of the patient. The pathology is that the internal anal sphincter is mainly responsible for anal closure and continence during rest, while the external anal sphincter plays a main role during increased intra-abdominal pressure during coughing. So the perineum stretching during vaginal delivery can cause anal sphincter injury by direct trauma to the muscle or by injuring the pudendal nerve. So this is the classification by Sultan, which was given in 1999. And it was revised when they further subclassified the third degree tears. So according to this classification, first degree involves only the vaginal mucosa or the perineal skin. The second degree involves the muscles with anal sphincter, and the third degree tear involves in 3A less than 50% of external anal sphincter, and 3B is more than 50%, whereas 3C is non-external and internal sphincter. And the fourth degree is a third degree tear extending to anal mucosa. It is seen that perineal trauma is not included in Sultan classification, which may include labial lacerations, periurethral tear, vaginal side wall tear, and cervical tear. But what we should understand is if it is OASI, it is always third and fourth degree perineal tears. Next, please. So how do we diagnose? So clinical assessment is very important at the time of delivery, and it plays a very important role in early diagnosis, and imaging can be done when it is a late onset presentation. So what we must take home from today's point is that routine rectal examination is a must after every episiotomy repair. There's a study by Fernando et al. Who conducted by RCOG, and they found that 33% of obstetricians degree injury a second degree injury, and 22% of residents consider third degree injury a second degree injury. So careful examination by a vaginal touch and rectal touch should be done after childbirth. Next, please. Ultrasound. So we can take transverse and longitudinal orientations. What we see on ultrasound is, next slide, please, that internal, like the internal sphincter and the external sphincter both can be visualized on transperineal or endovaginal ultrasound. Can I just go back? 3D techniques can be used for volume measurements and multiplanar reconstructions. Patients can lie in left lateral or lithotomy position. We can do a transrectal, that is endoanal. We can do a transvaginal, or we can do a transperineal using high-frequency transducers. Next, please. Next. So this is the picture of certain some amount of injuries or irregularities in the sphincter, which we observe when we do an endoanal ultrasound to detect external anal sphincter defects. Next, please. MRI can also be used, and anal sphincter injury appears as hypo-intense disruption of the circular sphincter. So here you see this, the second picture is on Valsalva maneuver, and this is without, where you can see the internal external sphincter. Next, please. So how do we prevent? So prevention is definitely better than cure. So how can we prevent this? The GTG in 2015, number 29 tells us that mediolateral episiotomy should be considered specifically if you're using instrumentation, which will prevent OASIS. And where indicated, it should be a mediolateral and with careful attention to ensure that the angle is about 60 degrees away from the midline. And it should perineal protection at crowning and be protective. Warm compresses is supposed to be helping and prevent OASIS. And definitely we should not forget to do a per-rectal examination after suturing the episiotomy. Next, please. So treatment can be conservative or surgical depending on the degree. So we can go for conservative management in first and second degree. We can use ointments, pelvic floor physiotherapy, but definitely third and fourth degree perineal tears should be surgically corrected to regain the anal continence. And the repair techniques include end-to-end and overlap repairs. And if the nerve injury is there, you need to do sacral nerve modulation, which will help strengthening the pudendal nerve. Next, please. So this is a picture which is showing the overlap techniques, so where we have to enter through a distance and then go back and come. So this is how we are supposed to do an overlap technique. Next, please. And this is the end-to-end anastomosis. So we can take stay sutures. At the end, we've got to suture all this. So one technique, both techniques are equally effective for maintaining the continence. Next, please. So it should be done by a senior obstetrician in OT with good light. We can use 3,0 polygalactin sutures to repair the anorectal mucosa because it causes less irritation and discomfort than PDS. And when repair of external or internal anal sphincter is performed, we use either monofilament sutures like 3,0 PDS or modern braided sutures 2,0 polygalactin. And when obstetric and anal sphincter repairs are performed, we should see that we bury the surgical knots beneath the superficial perineal muscles because that will minimize suture migration to the skin. Next, please. Post-operatively, definitely we have to give broad-spectrum antibiotics so that there is no post-op infection and wound dehiscence. And post-operative laxative is recommended to reduce the risk of wound dehiscence. And follow-up is important. They should be advised physiotherapy and followed after 6 to 12 weeks. And if the woman is experiencing incontinence, she should be referred to a specialist or a colorectal surgeon. Next, childbirth after OASIS. All women who sustain OASIS in previous pregnancy should be counseled about the mode of delivery and it should be clearly documented. And the role of prophylactic episiotomy in subsequent pregnancy is not known. And therefore, an episiotomy should only be performed if clinically indicated. This is what the literature tells. But all women who have sustained OASIS in previous pregnancy, who are symptomatic or have abnormal endoanal ultrasound and or manometry should be counseled regarding option of elective cesarean section. There's something about rectal buttonhole tear. So this is very important. After the end of the episiotomy, if you put a finger in the rectum, sometimes the finger comes out like this. It is not included in 4th degree tear, but it has to be documented, properly repaired. If you don't repair, it may end up in rectovaginal fistula. Next, please. Something about medico-legal, because Dr. M.C. Patel is there. We have found that there are, he and Sir may tell us that there are rise in litigation related to OASIS. And majority of these are because of failure to identify the injury after delivery, leading to subsequent anal incontinence and fistulas. And occurrence is not considered a substandard care because it is known complication of vaginal delivery. However, failure to recognize this damage or carry out an inadequate repair is important. A poor technique, poor selection of materials, or poor healing may cause failure of proper repair. So to conclude, OASIS is common and getting more common. Risk factors should be kept in mind and preventive steps to be taken. It is said that vacuum delivery has a lesser risk as compared to forceps. So always when you remove the forceps after the delivery, you should dismantle the forceps. And prediction is impossible. Repair should be done by experienced surgeon. There is 3 to 13% recurrent risk, hence the parturition should be counseled. Proper counseling will prevent medico-legal implications. Thank you. Yes.
Over to the chairpersons. Over to the chairpersons, please.
Excellent presentation, Dr. Jyoti. And we should thank Patel sir for selecting this very important topic. Because nowadays, OASIS, I think, is coming more and more common, maybe due to more recognition. I think now this suggestion by the RCOG is that before suturing episiotomy, all cases we are supposed to do a PR. And after suturing episiotomy also, we have to do a PR. So we may need additional gloves. That is the only thing. So all cases before suturing episiotomy, do a PR. And then at the end of suturing also do a PR. That is the best way to identify the OASIS and treat it properly. See, everything I think Jyoti Madam has covered.
Jyoti, just an excellent presentation. But the main problem with the OASIS is difficult to diagnose it. Even if you do a PR or before or after, you may not be able to detect it. But if you are routinely doing for endoanal sonography, then you may detect all these things. But regarding the continence, even after repair, when will you go for this endoanal sonography to find out how much repair has occurred? Whether if the repair is not complete, whether it is of a legal any importance. All these are a gray areas of discussion, is it not? And Jyoti, what suture material you use for internal anal sphincter repair?
PDS 30.
30 PDS.
And it is that even after cesarean sections, you can have OASIS because of pregnancy changes.
No. If it is done in labor, there is a chance. But if it is not done in labor, there is no chance. So will you recommend cesarean section to prevent OASIS?
That's it. Some people don't want any injury there, then definitely cesarean on demand.
Yeah.
Many patients are suffering silently, actually.
Yes.
Out with it.
Anybody has got any experience with anorectal manometry, then impedance spectrometry for diagnosing OASIS?
Would you repeat that, sir? What did you say?
For diagnosing the present modality which we are having is best one is 3D endoanal sonography. Then MRI is not maybe of use some, but they are suggesting that anorectal manometry, then impedance spectroscopy, all these are good, especially for result gate, best to diagnose anal incontinence.
I think, sir, the usual recommendation is if the symptoms are persisting at 3 months, we have to do an endoanal ultrasound. So that is the only one that is recommended.
The main problem is majority may not be having this endoanal probe, is not.
Sir, a transvaginal probe will work, will it not?
It won't, because you won't get the whole circle.
But a bigger probe, perineal probe can.
So all these are we are compromising in diagnosing and then going for the treatment. So the main problem is if it is patient is having symptom and then it is diagnosed with endoanal sonography, it is better to go for cesarean section in the next pregnancy, is it not?
Yes. It is a recommendation. MC Patel, sir.
Yes.
So, sir, we have reached the end of our session.
Yes. Was there any question for me?
Yes, there was one question.
You have time now. You can have the question, sir.
Okay, Nini, somebody was asking question. What was the question?
16-year-old girl comes for MTP with a boyfriend. How to informing the police?
If our center is registered and if we are qualified, we can terminate pregnancy, but we have to inform police. And we have to inform police that we are going to terminate pregnancy of that very girl at on. Please send your representative to collect product of conception. We will preserve product of conception in normal saline. And we will have to mention what is the importance of product of conception to be collected well in time and to be sent well in time for DNA testing, etc. Because if police doesn't turn up, after 72 hours, this product, whichever we have collected, will not be that useful as far as DNA testing, etc. is concerned. Because we have to preserve in normal saline only. We cannot preserve in formalin also. And if police doesn't turn up, then your job is over. Once you inform, you have not to wait for police to come. You can very well terminate pregnancy, no issue. But with all the documents related to that very case, you should be very clear in maintaining all the documents. Say, for example, consent in Form C from guardian, Form number 1, that is opinion of one registered medical practitioner. If pregnancy is more than 20 weeks and less than 24 weeks, then opinion of 2 registered medical practitioners. That way, we have to maintain all the records because these are the potential cases which may go in court of law and you may be asked in court of law as an expert witness to opine. So we can terminate pregnancy, no issue.
If the police is not coming, if the
Pardon?
police is not coming for collecting specimen, how long we have to keep specimen?
72 hours, because after 72 hours, whether you have kept it or not, it will not be useful. Na? But in this situation, to be on safer side and not to end up into any problem in future, next day you can inform police again that product of conception is preserved in normal saline. It is with us. Please send your representative to collect it and send it for further investigation. If you are not collecting this within 72 hours, it won't be that useful as far as DNA testing is concerned. So it shows your concern that you are utmost careful to preserve that specimen and that specimen to be useful as far as opinion forming is concerned. If police doesn't turn up, that is up to them. Your job is to inform. Yes, Vinay Chandra, you were telling something.
Is it necessary to write the Aadhaar number of this victim and
determination of age is on shoulder of doctor to determine, because in court of law, whenever you are asked what was the age, you will have to prove. If clinically, if she is major, fine. But if at all you are in a little doubt that she could be minor, then you have to ask for any ID proof you can ask. Aadhaar card, school living certificate, election card, any ID proof you can ask. And not only that, when you attach that ID card with your case paper, then get that copy attested by patient and relative. Because we never know, this copy of Aadhaar card could be fake one. You can verify with original one. You can verify by computer also. Now it is also available that you can verify whether this copy is regular or fake. But not to end up into problem, it is to be attested by patient and patient party.
When the girl is 16 years, it comes under the POXO Act, is it not?
Yes, less than 18, any girl.
Yes. Excuse me, sir.
Yes, welcome.
Sir, under 16, under means the POXO Act, if a child comes, I mean, with bleeding PV, which is incomplete abortion. So, as you had said, for above 18, if she comes in incomplete abortion, or maybe she's already expelled her products and little bit is remaining, it doesn't come under the purview of MTP Act, and it becomes an incomplete abortion. If an under 18 lady comes with bleeding PV, it is very difficult to make out whether it is, POC coming, or like sometimes they'll come with tablets which have been taken on OTC and they come to the hospital. We don't realize actually whether they are really bleeding because of an MTP which has been taken or simply bleeding. So would we be I mean, would we be in the purview of POXO Act if we don't inform these things?
If patient is less than 18 and if she has come with this type of complication, on interrogation, when we ask history, if she gives history of, say, for example, 1.5 month amenorrhea or 2 months amenorrhea and history of over-the-counter pill, then it becomes little suspicion one day she could be pregnant. And whenever this type of product passes, when you are going for evacuation, you can send it that product for HP also to confirm. And if it turns out to be product of conception, it becomes a case of POXO. You have to inform police.
And also you can take the blood sample for beta HCG.
Yes, you can have blood sample for beta HCG also. Yes, it is also one more abundant caution to prove that she was pregnant.
Pregnant, yes.
Sir, just out of curiosity, it might be out of place, but then if such a XYZ lady has been has already passed POC and on scan these things are not seen, like POC is not seen per se, is there any number of days till which some amount of fetal DNA or something might be found in case this becomes a proper strong rape case or something of that sort, if we couldn't get any POC at when she came in the hospital, or if it was misplaced due to any some reason, is there any time purview by like for third day or fourth day till which we can get a fetal DNA? Just asking,
So,
sir, out of curiosity.
in law, it is very clear dictum. Law doesn't teach you medicine. We have to practice medicine as per standard medical norms. In this situation, our job is to inform police if at all you have a little suspicion. If you are not sure, then you will write to the police, I have suspicion. Because when you are not sure of your opinion, because in court of law, whenever you are asked to opine, you should be in a position to justify your opinion with all the evidences. So if you have no evidence and if you are in doubt, then you have to inform police that way.
Okay. Okay. One similar case was there, but she was not an underage. She was 21 years, but unmarried. She came for termination. Of course, termination was done from our center because right now we don't require a husband's signature, and she was means live-in partner. That's what she said. But then after the termination and everything was over, she has then registered a rape case against that boy. Now the police came and told that how could you terminate without the signature of the husband and all those things.
What was the age of patient?
21.
21. So I mentioned in one of the discussion, when patient is major, only
Yes,
patient
sir.
can give her consent. So as far as termination part is concerned, no consent of husband is required. MTP Act is very clear that way.
Yes,
So if you have not
yes.
taken consent of husband, you are not at all legally in purview. So you are
Yes.
safe. But if she is unmarried and if she is major, then I mentioned during discussion, you have to take in writing that this is a result of consensual sex. I have no complaint against anybody. I do not want to inform police. So at that point
Yes.
of time, she was very clear. She had no complaint
Yes.
against anybody. In future, if she made up mind to lodge complaint against anybody, that is up to her. But how doctor can judge that she is going to complain in future and why you didn't inform police? So you have to simply be careful in this type of situation.
So it's
Mm-hmm.
better
You
to
also
inform
mentioned
police,
that police might harass us. You also
Police-
mentioned that police might harass us. I think that is what is going on.
But when we are legally clear, then we can very firmly say that there is no
Yes.
provision in law that consent of husband is required. Show me.
Ha. Yes, sir.
You should be firm at the time of dealing with police.
Yes. Okay. Yes, sir. Thank you, sir.
Suppose, sir, a 16-year-old girl comes with this, comes with an ectopic pregnancy, then
in any situation, once you come to know that she is minor and she is pregnant or she is victim of sexual offense, you have to inform police. Naturally, you have to deal with situation first. Because ectopic pregnancy, you have to deal first. And then before patient leaves your premises, you have to inform police.
Sir, another thing, is there any way that that MTP which I was mentioning that time, can it be regarded inside the MTP Act, and one simple sentence can be kept that it should not be given as an OTC. There are so many prescription only pills which are available. Pharmacy
Okay.
cannot give it without prescription. Similarly, something can be done.
In MTP Act, it should not be there, or it should be there, not the question. But to sell this product over the counter is crime. So if one's lodge a complaint with all the evidences that very pharmacy has sold this medicine to this patient with this bill, etc., then they will be in a big trouble, because it is medicine prescribed at unauthorized place, medicine prescribed by unauthorized person. and there is a provision of imprisonment 2 years to 7 years. But there should be proof to prove, because
They never give a proof.
then
They don't give prescription. They don't
in eye
give
of law, what happens? In eye of law, what happens?
documentation.
Court goes with evidence only. Party
Evidence.
It's available online also.
Party who can put his or her case with all the evidences win the case. So in that very case, you should be in a position to prove that that very pharmacy had sold this product over the counter.
It's available online also. Amazon.
But if it is available online, then it can be checked by Food and Drug Department. But Food and Drug Department is not serious to check it. Then what we can do?
Asha madam will do.
But for that you will have to vote her, and you have to elect her as a chairperson of Food, Drugs and Surgical Medical Equipment Committee (FOXI), and she will take this case, and she will take case with me only, because if you vote for me and if I am President FOXI, I am going to take not only this question. There are so many issues related to our practice to take at government level to clarify certain provisions. Not only in MTP, PCPNDT, ART, surrogacy, there are so many work to do. And that is why I am always saying in my lecture also. So whenever you need me, I will be just round the corner. Until
Yes,
now,
sir. I guess all the participants here will be voting for you both only.
Thank you.
Thank you so much. Omana ma'am is still there. So Omana ma'am, would you like to say something? Our guest of honor is still there till the end.
Yes, yes, very, very nice discussion. Very, very fruitful. Sir, so many legal points have been brought out. And thank you very much, sir. And we'll be in contact with you whenever we have some problem. Hope we won't have.
Thank you. Thank you. Thank you.
Requesting
all the
everyone
best, all the best, both of
please
you.
put
Both
on
of
your
you.
videos. I'll take a picture. If everybody please puts on their videos, I want to take a picture. Dr. Kalpana, Dr. Shiv Kumar, Dr. Vidya, Dr. Maya, Dr. Mini. I've taken a screenshot, ma'am. I'll share in the group. Dr. Lakshmi. Yeah. Yes, Vidya, ma'am. Yes.
Shivakumar is not there, no?
Okay, one by one. Yeah.
Oh, yes.
Dr. Asha, please put it in the group.
Yeah, I will share it in the group, ma'am.
Okay.
Dr. Mini only remains, and then we are done. So thank you. Thank you so much for spending your evening with us and enlightening us with all your knowledge and your participation. It is your active participation that actually makes the program worthwhile, and it makes it valuable to our listeners. So I thank all the respected faculty, the convener, coordinator, chief guests, guests of honor, all the chairpersons, speakers, panelists, and MC Patel, sir, for having me here and giving me a chance to interact with everyone. Thank you, delegates. And we meet again next Tuesday with another topic. Namaskar.
Thank you so much for the opportunity.
Thank you.
And wishing both of you all the very best.
All the best. All the very best.
Thank you. Thank you so much.
Bye-bye. Good night.
Bye. Good night. Sir, if with due permission, may I end
Oh,
the
yes,
session?
we can.
Thank you.
Okay, good night.
Good night.